Nephrolithiasis. Nephrolithiasis refers to calculi or stones in the kidneys. The stone may form in kidneys but may be passed to the ureters and the lower urinary tract. The lifetime incidence of kidney stones is nearly 13% in men and 7% in women. Once an individual has formed a stone, the likelihood of recurrence is 50% or greater at 5 years and up to 80% at 10 years. In Indian population, about 12% of them are expected to have urinary stones, and out of which 50% may end up with loss of kidney functions. Formation of stones may be the result of a low fluid intake, with a subsequent low volume of urine production, that produces high concentrations of stone-forming solutes in the urine. The other causes include elevated urinary levels of calcium, oxalate, and uric acid, and reduced urinary citrate levels. Two phenomena are responsible for stone formation. Firstly, supersaturation of the urine by stone-forming constituents, including calcium, oxalate, and uric acid. And secondly, deposition of stone material on a renal papillary calcium phosphate nidus. There are main four types of renal stones: calcium, struvite, uric acid, and cystine stones. The classic presentation for a patient with acute renal colic is the sudden onset of severe pain originating in the flank and radiating inferiorly and anteriorly. At least 50% of patients will also have nausea and vomiting. Patients with urinary calculi may report pain, infection, or hematuria. Patients with small, non-obstructing stones or those with staghorn calculi may be asymptomatic or experience moderate and easily controlled symptoms. The location and characteristics of pain in nephrolithiasis include the following. Stones obstructing uretero-pelvic junction manifest as mild to severe deep flank pain without radiation to the groin, irritative voiding symptoms, suprapubic pain, urinary frequency or urgency, dysuria, bowel symptoms. Stones within ureter manifest as abrupt, severe, colicky pain in the flank and ipsilateral lower abdomen, radiation to testicles or vulvar area, intense nausea with or without vomiting. Upper ureteral stones manifest as pain radiating to flank or lumbar areas. Mid-ureteral calculi manifest as pain radiating anteriorly and caudally. Distal ureteral stones manifest as pain radiating into groin or testicle in men or labia majora in women. Stones passed into bladder are mostly asymptomatic. Rarely, positional urinary retention may be there. Clinical examination findings may include dramatic costovertebral angle tenderness, generally unremarkable abdominal evaluation, constant body positional movements, tachycardia, hypertension, and microscopic hematuria. Laboratory testing may help in determining the renal function and the nature of stones. Imaging studies may help to visualize the stones in the urinary tract and confirm the diagnosis. In any acute attack, the management involves intravenous hydration, non-steroidal anti-inflammatory drugs, analgesics, alpha blockers, antibiotics, and antibiotics. Stone prevention involves administration of uricosuric agents, alkalinizing agents, and thiazide diuretics. Surgery is needed for stones that are 7 mm and larger and are unlikely to pass spontaneously. Many types of surgeries are available. Approximately 80 to 85% of stones pass spontaneously. Approximately 20% of patients require hospital admission because of unrelenting pain, inability to retain enteral fluids, proximal UTI, or inability to pass the stone.